ವೀಕ್ಷಕರಿಗೆಲ್ಲ ನಮಸ್ಕಾರ. ಇವತ್ತು ನಮ್ಮೊಂದಿಗೆ ಇಬ್ಬರು ವಿಶೇಷವಾದ ಅತಿಥಿಗಳು ಬಂದಿದ್ದಾರೆ. ಇವರು ವಿದೇಶದಲ್ಲಿ ಮನೋವೈದ್ಯ ವೃತ್ತಿಯನ್ನು ಮಾಡ್ತಾ ಇದ್ದಾರೆ. ಮೊದಲನೆಯವರು ಪ್ರೊಫೆಸರ್ ಟಾಮ್ ಪಾಲ್ಮಿಸ್ಟರ್ನ ಅಂತ, ಮಧ್ಯದಲ್ಲಿರೋರು ಡಾಕ್ಟರ್ ಪೀಟರ್ ಲೆಪ್ಪಿಂಗ್ ಅಂತ. ಇವರು ನಮ್ಮ ಮೈಸೂರಿಗೆ ಸುಮಾರು 1 ದಶಕಗಳ ಕಾಲದಿಂದ ಅಕಾಡೆಮಿಕ್ ಆ್ಯಂಡ್ ರಿಸರ್ಚ್ ಕೊಲಾಬರೇಷನ್ ಮಾಡ್ಕೊಳ್ತಾ ಬರ್ತಾ ಇದ್ದಾರೆ. ಇವರೊಂದಿಗೆ ಇವರ ಅನುಭವಗಳನ್ನ ಬಿಚ್ಚಿಡೋದಕ್ಕೆ ಈ ಒಂದು ಚಾನಲ್ ಮುಖಾಂತರ ನಾವು ತಮ್ಮ ಮುಂದೆ ಪ್ರಸ್ತುತಪಡಿಸ್ತಾ ಇದ್ದೀವಿ. ಸೊ ಆನ್ ಬಿಹಾಫ್ ಆಫ್ ದ ಚಾನಲ್ ಐ ವೆಲ್ಕಮ್ Professor Tom Palmstierna and Professor Peter Lepping. Now, I would like to ask Professor Tom Palmstierna first, as a matter of seniority, to tell me about your background for our viewers.
Thank you. Thank you for having us here. I'm a doctor, I'm a psychiatrist, and I've been working as a psychiatrist for almost 4 decades in Sweden, Scandinavia. And I'm also a researcher in the field of psychiatry, and I'm a professor at the Karolinska Institute in Stockholm and Norwegian University. So that's roughly my background.
Yeah. Yes. Thank you, Tom. What about you, Peter?
I'm Peter Lepping. I work as a psychiatrist in North Wales in the UK. For quite a few years I have worked as a community psychiatrist, so anybody who got psychiatrically ill in the area that I covered would come to me and the team that I work with. But now I'm working in the hospital, so in the general hospital itself, which means that if anyone on the medical or surgical wards has any kind of psychiatric problems, for example, depression, anxiety, confusion, dementia, then they would ask me and my team to see them and help.
Thank you, Peter. Peter, you've been in India much before Tom.
Mm-hmm.
So, what similarities and differences you found between the mental health services in your country, UK and India? Can you just tell a few points?
Yeah. Starting with the similarities, one thing that is the same in the UK and here is that there is a big emphasis on working in teams. So not just having a doctor, but also having psychiatric nurses, psychologists, occupational therapists, pharmacists, and they all work together in a team to try and help people with mental health problems. That is very similar here and in the UK. Another thing that's similar is that here and in the UK, we try to help people with psychiatric problems as close to their homes as we can possibly do it. So there is a community approach to the treatment, and we try to get the treatment to the patient rather than forcing the patient to come to us. Obviously, if people need hospital treatment, then that has to be delivered in a hospital. But many things in psychiatry can be delivered outside of a hospital. In fact, probably 95% of everything can be delivered outside a hospital, and that's the focus here and the focus in the UK. Another thing that is similar is that the teams are usually led by doctors, even though there are some teams in the UK that are led by nurses, by senior nurses as well. Now, some of the things that I found different, one thing, for example, is the degree of family involvement. Whilst in the UK, families do get involved and they are often central to helping people recover, they don't have the same automatic rights that they have here. So here I see that, for example, if you want to be admitted, that is usually a family member that has to accompany you into hospital. whereas in the UK it's the exact opposite. People are discouraged and they're not allowed to stay. Having said that, there are some changes now where in dementia treatment we are now looking in the UK at allowing relatives to stay, because we find it's usually good for the patients. So that's a big difference. Having said that, sometimes it can also be a slight disadvantage, but I think we'll get to that with the later questions. So that's a big difference. Here you have to have the relatives with you in hospital. In the UK, it's more about the individual rights of the patients and the confidentiality around that particular patient. So if you have a patient who says, I don't want my family to know anything, then there's nothing really we can do about that, unless they clearly lack the capacity to make that decision. But that can cause conflict within the families as well, because often the patient then goes back to the family but doesn't want the family to be informed. So that's one of the differences. Another big difference, I would say, are the resources, because you will probably be all aware that Europe has one of the biggest spend per GDP in the whole world on health. We have a system where anybody gets free treatment at the point where they need it. It's all paid through taxation. And the UK, for example, spends about 12% of their health spent on mental health, whereas in India it's about, I believe, 1%. So it's an enormous gap in resources, and you can see that because here there are far fewer psychiatrists, far fewer mental health nurses, far fewer facilities, and that is something that obviously has an impact.
Thank you, Peter. Tom, you've been a very rigorous researcher. So, in your point of view, what are the good features in Indian mental health?
Well, as far as I've seen, the Indian mental health is of high quality. Methods used are rigorous. They are evidence-based methods, both with regard to pharmacological and psychotherapeutical approaches. And the good thing, which is good and both good and bad, it is also the family involvement that you mentioned, because what we lack in Europe, in UK and Scandinavia, is when patients are getting out of hospital, they need a context to live within, and if the family is not involved, what we don't have an outreach after hospital. But that is at the same time, if you rely too heavy on family, those without a family network will fall on the side. And also, if we say that the family should support the mentally ill individual, I think also we should think in terms of that the family needs support, because you can't look aside, but chronic mental health problem is a burden for the patient, but it's also a burden for the family, and it is I would guess, if one has a systematic support of families, the outreach would be better, and the outcome would even be better. Even though you have in India a better outcome on chronic psychotic individuals, probably because you rely on the family to care for the patient, which means that you have many more carers than if we only have our own hired staff.
Yeah.
So that's a good way that should be kept, I think, and we have a lot to learn. I would like to take that more home to Scandinavia, but it touches also the thing that I mean is what you need, and you touched about that question about funding, but it's the outreach. Keep the good psychiatric clinics you have here, and let them get an outreach. The outreach then includes more budget, of course, but you could do it, I think, quite effective if you, in a way, use some of the support for the patient to support for the family. And it means that you also need to use a budget for education. You need to educate people to be carers. Otherwise, you can't have an outreach. And I think if you get to that point that you get a better funding and get resources for education, then I think you could use that momentum, because outside, as I understand it, outside the bigger cities, there's not much psychiatry at all. That's a bad thing in one way, but if you get the opportunity, it's an opportunity for you to develop outreach activities in a more planned way. So if you get possibility to outreach and budget and education, catch that moment, because it could be a golden moment for you to develop.
Yeah, thanks Tom, because you have pointed out good factors, and also you have suggested some improvements like the outreach and cutting down the burden of the family members. Even though family members help patients' recovery, but still
Yes.
we need to focus the burden that happens to the family. And then when we talk about outreach, of course, there has to be some budgeting, and then the level of awareness, education to both patient and caregivers has to improve. Then there are people who are unreached. So the psychiatric care has to be equally distributed across not only the cities but also far reach rural areas. And also there are many tribal regions within India. So that equal distribution is something that you suggest. Are there any more improvements that you would like to?
Well, when you mention those aspects, I would say I would stress that yes, it's a burden for the family, but lessen the burden by supporting the family. It's a way of putting it the other way around. And I guess also that there are quite big differences between awareness on mental health issues in the larger cities as compared to rural areas. And what falls into my mind then is how could one increase awareness of that this is a mental disorder that needs treatment and not something else. Perhaps some educational for people outside the big cities.
Yes.
So increase the understanding for mental health.
Yeah. Thank you, Tom. Peter, do you want to add anything more? Since you've been attending many conferences in India and you have interacted with quite a few psychiatrists within India, what do you feel the areas that needs improvement in mental health service in India?
I'm very much with Tom on this question, but there's two things that I would like to add. One is that awareness for mental health problems is really important, but it always has the slight risk that if it's not backed up by actual treatment, it can cause a problem of unmet need, because people may then be more aware that they are ill and should have treatment, but if that treatment isn't available, then there's a possible problem there. So I think it's important that awareness campaigns go hand in hand with the availability of treatment. And the second thing I wanted to mention is the use of technology. And COVID has been a challenge in any country, and but it also showed us that we can do things differently when we have to, and we have been very flexible in many countries and found new ways of delivering healthcare. And with so many people in India having mobile phones and access to mobile phones, it is quite possible to actually make sure that part of the outreach and part of the resource issue could potentially be solved by using technology to open up access for mental health care to people in more remote areas, but even in urban areas, if that's needed.
Yeah, thanks, Peter. I understand the suggestion about technology because India is one of the forefront leaders in the information boom. So everyone has now digital transactions and then they all have smartphones. So probably this is one area where government can look and then invest more to fulfill the unmet needs. Peter, I want to ask you, since you are a visiting professor to the Department of Psychiatry, Mysuru Medical College, there has been a lot of research going on from past 1 decade. Of course, Tom is in our team and few others from the EVIPRIC committee from Europe are also supporting us. Can you briefly tell us about the research collaboration that's happening between Europe and Mysore Medical College?
Yeah. I should also probably mention the team around Professor Rob Poole from the Center of Mental Health and Society. The research that we have been involved in that stems out of the European Violence in Psychiatry Research Group is research that is primarily engaged with finding out more about coercion, coercive treatments, violence on psychiatric units, and how we can measure and reduce that. So the first starting point was that we looked at how much violence and aggression exists in medical wards, in psychiatric wards, in various hospitals in India. And Tom developed a way of measuring that reliably, which we have applied here in Mysore as well. And we've had some first publications around that, which were really interesting. The second step was then also to ask people what they feel about coercion. So coercion is basically when people are forced to do something that they don't really want to do. For example, they may get medication against their will, or they may be held down on a bed against their will, something like that. So we asked patients and we asked relatives, we asked doctors how they feel about using coercion, how it makes them feel, what it does to them, whether they think it's necessary, and what kind of things could be done to reduce coercion. So that is the kind of research that we've done in India, and we've got quite a number of very good answers. There are differences, but also similarities. For example, if you are admitted into a psychiatric hospital in Mysuru, you are more likely to get some form of coercion at some point during that hospital stay than you would be in Europe. At the same time, when we asked people whether they would be willing to work with doctors to actually come up with good individualized plans for their care, patients in India were much more likely to want to do that than the experience we have with patients in Europe or in North America, for example. So there are really interesting similarities and differences, but obviously we've done this in Mysore, we've done some of the research in Bangalore. It would be interesting to have more centers join the research so that we could get data that would actually apply for bigger parts of India rather than individual hospitals.
Yeah, when you spoke about reducing the coercion, Mysore Declaration was developed in association between DAIVIK and then the India.
Mhm.
So, can you say a few words about Mysore Declaration on reducing the coercion?
Yes. So we organized a big conference here in Mysuru that was attended by people from the DAIVIK research group. So that the DAIVIK research group combines a lot of European, but also now some American, Australian, and Indian researchers who want to know more about coercion and how to reduce it. And this group is really quite instrumental in doing a lot of the work on coercion in Europe. So we've set up a conference where we had experts from India and experts from this research group around the table, trying to find out what we can do to come to the aim of reducing coercion here in India. So we started off by defining what coercion actually is and the different types of coercion people might use. For example, holding someone down, giving someone medication against their will, possibly using belts or other mechanical means to immobilize someone, putting someone in what's called a seclusion room, which is a sort of empty room where they can calm down. And so we defined all these measures, so we knew we were talking about the same things. And then, led by the Indian experts, we tried to define what the basic standard ought to be and where we want to go. So we want to get to a place where coercion is the absolute last resort and something that is eradicated as much as we possibly can. And that is the aim of the Mysore Declaration, and it shows a number of ways how to get there. And it's freely available on the internet if people are interested. Just put in Mysore Declaration.
Yes, Peter. I should tell you that some of the points from Mysore Declaration was answered, or rather framed under the legislation in the new Mental Health Care Act that was passed in 2017. That's quite promising for the team between India and the Europe working on this area. Now, I should finally ask you, what are your research future plans to take forward this collaboration?
Part of our plans are to find out more about the reality of patients with chronic psychiatric problems in India who are looked after by their families.
Yes.
And so we want to learn more about what the reality is for people in their own homes when they're looked after by their families. How do families manage the difficulties that this may create? And do the patients feel coerced when family members, for example, put certain restrictions on them? We don't even know what exactly the restrictions are and how people feel about them. So we would like to do some qualitative research to find out what the actual experience of patients and carers is. And then the next step would be to set up programs of education for carers about coercion and then see whether those programs make a positive difference in reducing perceived and actual coercion. So that's the broad plan for the future.
Thank you, Peter, because I think this is focusing what the new Mental Health Care Act is primarily based on the rights of the patient. So, on behalf of the media, I would like to thank you both for sharing your experiences between your own countries and what have you observed in India over past decade. And we are very thankful that you have plans to continue this collaboration. Not only that, you are part of one of the first state medical colleges, that is Mysuru Medical College, and guiding our postgraduate students in psychiatry. And I thank the media because what's been happening within the lab has been brought to the awareness of the public. I think when public awareness improves, as both the specialists were mentioning, it gets into the treatment plan. And then, depending on the outcome, we can always go on improving further what best can be done both to the patient and the caregivers, thereby improving the quality care for the patient and reducing the burden of the family members. So, thank you very much.
Thank you.